Hello everyone, we are the Group 2 and we will be presenting the taking capillary blood glucose and insertion of Foley catheter for male and females.
Taking capillary blood glucose. A blood drop sample is usually collected from a fingertip prick. Blood samples can also be sourced from alternate sites such as the earlobe, heel, forearm, and palm. Alternate site testing provides similar results to finger prick testing, especially in the fasting and 2-hour post-meal times. Using alternate sites may be less painful but may need a deeper lens. Check with the manufacturer of the glucometer if the machine may be used for alternate site testing. Equipment used includes a lancet used to prick the skin, a glucometer, and test strips. Glucometers have a range of features, with modern smart machines requiring a very small sample of blood from 0.3 to 1 microliter, have Bluetooth capabilities that synchronize data with paired applications or apps on smartphones. These machines and apps record data and provide trends in glucose measurements undertaken. Furthermore, some apps also provide options to record diet and medications used, type of physical activity undertaken, which may be useful to the healthcare practitioner when managing the care plan for the client with diabetes. Moving on, for its advantages, we have small blood sample, range of alternate sites capable of testing, short testing time, large display on glucometer, and less painful than venipuncture. And for its disadvantages, manufacturers often provide low-cost or subsidized glucometers but sell testing strips and accessories at a significant profit margin. The test strips are expensive, time-limited or short expiry dates, and are affected by a range of variables including temperature, humidity, size, and quality of blood sample. Accuracy of the results is dependent on the clinical presentation of the client and may not be very reliable in clients with hypoglycemia, anemia, altered hematocrit, hypotension, or those who are critically ill. Older machines may need calibration with test strips, and results could be compromised if the calibration is not undertaken appropriately. For the continuation of this report, here is Ms. Medrana.
Thank you, Ms. Bacol. So moving on to the importance of the capillary blood glucose. Capillary blood glucose monitoring, or the CBGM, plays an important part in achieving levels of diabetes control, which are associated with reduction in the risk of developing diabetes complications. It is vital that the results of CBGM are used to adjust treatment to achieve the recommended blood glucose targets. Then for the procedure, collect the equipment, introduce self, explain to the client what you are going to do and why it is necessary. Wash and dry hands and site. Skin or site preparation if required. We should take note that the recommended site on palm is the side of distal ends of fingertips to minimize injury to the bone. Avoid the little finger as the tissue may not be deep enough to prevent injury to the bone. Avoid the index fingers and thumbs as these are highly sensitive areas compared to other fingers. Avoid the arm if an intravenous infusion is underway or is the side of the body where a recent mastectomy was performed. Heel stick stub, if done, can be more painful and may require resampling, so we should consider pain management in the neonate. The preferred site on the heel is the lateral or the medial plantar surface for babies up to 1 year of age. Then prepare the equipment. Prime the lancet to no more than 2.0 millimeters to minimize the risk of bone injury. Remove the glucose testing strip without touching the sensor tip from the container. Insert glucose testing strip into the glucometer. This often leads to the glucometer turning itself on. Firmly apply lancet to the site of sample collection. For the next step, release the trigger on the lancet to pierce the skin. Recommendations are to wipe away the first drop of blood with clean gauze or tissue, as this drop of blood may contain intracellular or interstitial fluid or is hemolyzed, both of which could affect the blood sample. Gentle downward pressure applied close to the puncture site may facilitate blood flow and collection of the second drop of blood. Collect the second drop of blood as it forms by touching the tip of the glucose testing strip. Place glucometer down and cover the site of skin puncture with a clean tissue. Pressure may need to be applied to stop further bleeding from the puncture site. The machine normally provides a result at this stage unless there have been errors in collection. For example, insufficient sample, low battery, wrong code, or the machine times itself out. If an error displays on the glucometer, troubleshoot as appropriate. Then perform proper hand hygiene. Make a note of test results relative to diet, exercise, and/or medication use as appropriate. Then document the procedure. Blood glucose is measured in mmol per liter or the millimoles per liter or the mg per dl, which is the milligrams per deciliter. So for the normal range of the blood glucose, through the action of hormones, blood glucose is normally maintained at about 100 mg or milligrams per deciliter. For the next report, insertion of the Foley catheter will be discussed by Mr. Glenn Pacada.
The next one is the insertion of Foley catheter. In urology, a Foley catheter, named for Frederick Foley, who produced the original design in 1929, is a flexible tube that a clinician passes through the urethra and into the bladder to drain the urine. It is the most common type of indwelling urinary catheter. Foley catheters should be used only when indicated, as use increases the risk of catheter-associated urinary tract infection and other adverse effects. Indwelling urinary catheters are mostly used to assist people who cannot urinate on their own. Indications for using a catheter include providing relief when there is a urinary retention, monitoring urine output for critically ill persons, managing urinary during surgery, and providing end-of-life care. Foley catheters are used during the following situation: on patients who are anesthetized or sedated for surgery or other medical care, on comatose patient, on some incontinent patient, on patient whose prostate is enlarged to the point that the urine flow from the bladder is cut off, on patient with acute urinary retention, on patient who are unable due to the paralysis or physical injury to use either standard toilet facilities or urinals, following urethral surgery, following uretrectomy, on patient with kidney disease whose urine output must be constantly and accurately measured, before and after cesarean section, before and after hysterectomy, on patient who have had genital injury, on anorexic patient who are unable to use standard toilets due to the physical weakness and whose urine output must be constantly measured, on patient with fibromyalgia, who cannot control their bladder, on patients who have severe skin impairment and/or breakdown. So we have here the goal to relieve discomfort due to the bladder distension or to provide gradual decompression of the distended bladder, to assess the amount of residual urine if the bladder empties incompletely, to obtain a sterile urine specimen, to empty the bladder completely prior to surgery, and to facilitate accurate measurement of urinary output for critically ill clients whose output needs to be monitored early. For the assessment, determine the most appropriate method of catheterization based on the purpose and any criteria specified in the order, such as the total amount of urine to be removed or the size of catheter to be used. Use a straight catheter if only a one-time urine specimen is needed, if amount of residual urine is being measured, or if temporary decompression or emptying of the bladder is required. Assess the client's overall condition. Determine if the client is able to participate and hold still during the procedure, and if the client can be positioned supine with head relatively flat. For female clients, determine if she can have knees bent and hips externally rotated. Determine when the client last voided or was last catheterized. If catheterization is being performed because the client has been unable to void, when possible, complete a bladder scan to assess the amount of urine present in the bladder. Next, we have the implementation. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you're going to do and why is it necessary or how he or she can participate. Perform hand hygiene and observe appropriate infection control procedure. Provide for client's privacy. Place the client in appropriate position and drape all areas except the perineum. For females, supine with knee flex, feet above 2 feet apart, and hips slightly externally rotated if possible. For males, supine, thighs slightly abducted or apart. Next, establish adequate lighting. Stand on the client's right if you are right-handed, on the client's left if you are left-handed. If you are using a collection bag and it is not contained within the catheterization kit, open the drainage package and place it at the end of the tubing within reach. If agency policy permits, apply clean gloves and inject 10 to 15 ml silocaine gel into the urethra of the male client. Wipe the underside of the penile shaft to distribute the gel up to the urethra. Wait at least 5 minutes for the gel to take effect before inserting the catheter. Remove and discard gloves. Perform hand hygiene. Open the catheterization kit. Place a waterproof drape under the buttocks of female or penis of male without contaminating the center of the drape with your hands. Apply sterile gloves and organize the remaining supplies such as saturate the cleansing balls with this antiseptic solution. Open the lubricant package. Remove the specimen container and place it nearby with the lid loosely on top. Attach the perfilled syringe to an indwelling catheter inflation hub. Apply agency policy regarding pretesting the balloon. Lubricate the catheter 2.5 to 5 centimeters or 1 to 2 inches for females and 15 to 17.5 centimeters or 6 to 7 inches for males and place it within the drainage and inside the collection container. If desired, place the fenestrated drape over the perineum, exposing the urinary meatus. Cleanse the meatus. Note that the non-dominant hand is considered contaminated once it touches the client's skin. For women, use your non-dominant hand to spread the labia so that the meatus is visible. Establish firm but gentle pressure on the labia. The antiseptic may make the tissue slippery, but the labia must not be allowed to return over the cleansed meatus. Note location of the urethral meatus is best identified during the cleansing process. For men, use your non-dominant hand to grasp the penis just above the glans. If necessary, retract the foreskin. Hold the penis firmly upright with slight tension. Next, insert the catheter. After that, hold the catheter with the non-dominant hand. For an indwelling catheter, inflate the retention balloon with the designated volume. Collect a urine specimen if needed. For a straight catheter, allow 20 to 30 ml to flow into the bottle without touching the catheter to the bottle. For an indwelling catheter, pre-attach a drainage bag. A specimen may be taken from the bag this initial time only. Allow the straight catheter to continue draining into the urine's receptacle. If necessary, attach the drainage end of an indwelling catheter to the collecting tubing and bag. Next, examine and measure the urine. In some cases, only 750 to 1000 ml of urine are to be drained from the bladder one time. Check agency policy for further instruction if this should occur. Remove the straight catheter when urine flow stops. For an indwelling catheter, secure the catheter tubing to the thigh for female clients or the upper thigh or the lower abdomen for male clients with enough slack to allow usual movement. Wipe any remaining antiseptic or lubricant for the perineal area. Replace the foreskin if retracted earlier. Return the client to a comfortable position and shock the client on positioning and moving the catheter in place. Discard all used supplies in the appropriate receptacle. Remove and discard gloves. Perform hand hygiene. Document the catheterization procedure including the catheter size and result in the client record using forms or checklists supplemented by narrative notes when appropriated. And lastly, for the evaluation, notify the primary care provider of the catheterization results, perform a detailed follow-up based on the findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Teach the client how to care for the indwelling catheter, drink more fluids, and provide other appropriate instructions.